So TB 101, the laboratory connection, as I said, the TB diagnosis in the vast majority is really done with the help of the laboratory. And before we start to go into the details, just a moment for reflection about a quote from Pericles, a Greek philosopher. The thinking human being, not able to express himself, stands at the same level as those who cannot think. And I believe this is still a very good quote to the times we are living in with COVID-19 and all the other stuff going on. So these are the topics I would like to address: an introduction, direct detection using a NAT, decision to discontinue airborne infection isolation in healthcare settings, AFB, smear microscopy, growth detection, identification including non-tuberculous mycobacteria, antimicrobial susceptibility testing, systems and algorithms, and then a presentation of a few laboratory reports which were de-identified from various hospital and public health setting, and then I close with acknowledgement. The journey sets the destination. As you can see, I actually spent my entire life in AFB, and I still love it. So for me, there was never an idea or a thought that I may leave AFB, because so much needs to be done. And the work, the collaboration with the clinician and TB program staff is so fulfilling. So I felt, no, this is really my hobby and my work. In terms of epidemiology, I just want to bring this to your attention. In 2019, there were a little bit less than 9,000 TB cases, and the case rate is 2.7. So we are making progress, but you see the curve is flattening. And in 2020, it went even down to 7,000, and we don't know actually why such a big jump. And the case rate is 2.2. Here again, I mentioned this in comparison then with the NTM, which here age 65 and older, a study from 97 to 2007, pulmonary NTM cases. And when you look now in this age segment, instead of the 2-3 per 100,000, we actually see by 2007 for women, which is the upper line, it is 55 per 100,000. So it's a different magnitude. And the men are the lower, with a little bit more than 30, and overall maybe a little bit average for both sexes, a little bit more than 40. So with other words, the pulmonary NTM, at least in the age bracket 65 and older, is 20 times the national average for TB. So it's not a rare disease. And another difference in terms of TB versus NTM, you can see white people, they're actually the female have a higher risk of pulmonary NTM compared to men, and overall African American black have a lower, and even the female have a much lower prevalence of pulmonary NTM. And then we have the Asian Pacific Islanders, Hawaii, and you can even say in Japan, it goes through the roof with more than 250 per 100,000. So with other words, and the Hispanics are even below the white. So with other words, there are pockets with the NTM pulmonary disease, which are many, many more frequent than the TB. And this brings me back to a recent study we did in Florida about positive AFP smear and the culture result. And as you can see, of the bars, the percentages are actually the last 3 years, 15, 2016, 17, the majority of newly diagnosed AFP smear positive respiratory specimens are in patients with NTM and not TB. And so this also begs then the question, we need as soon as possible assurance if this is TB or if this is non-tuberculous mycobacteria, because it has consequences for airborne infection isolation. And just so you know what is actually our charge in the laboratory, to provide the clinician/TB control with accurate results in a timely fashion. And here I can paraphrase that: quality comes before speed. Although we need to have speed, but the quality is important. When you have false results, then it's actually worse than if you have it right away. So with other words, it's really important to have accurate results. And here we depend on the collaboration with TB nurses and whoever is collecting, in a way, the samples we are testing in the laboratory. We have, in a way, two toolboxes. The number one is when we deal with a specimen, and specimen can be sputum, it can be cerebrospinal fluid, it can be formalin fixed tissues. Remember, you may have your own cases where the patient unfortunately passed away, and the autopsy, then you have only tissues, and they didn't expect TB. They throw it in formalin to do the histology, and then oops, there are signs of TB, and then one would like to see if this is really TB. So with other words, today with the molecular methods, we actually have a means to identify TB even in formalin fixed tissue. However, we cannot grow them because of the formalin fixation. Then the other thing is we need to decontaminate the sputum, because it's not a sterile site sample. There is a lot of other organisms in it. They grow faster than TB, and therefore we need to kill them. And when we are dealing even in a cystic fibrosis patient with a history of Pseudomonas, then we actually need to have even a stronger decontamination process, which we are using oxalic acid. Then, of course, smear microscopy, you are aware of that. Solid and broth-based medium, not only broth-based and not only solid medium. Then we have the NAT-D and the NAT-R. Even we are not in a campaigning season. It doesn't stand for Democrats and Republicans. It stands for NAT diagnosed, direct, and the R for resistance. And there with the NAT-D, some laboratories are, because of the frequency of AFP smear positive patient being ultimately NTM patients, they do also an PCR for MAC, microbacterium complex, which is the most seen NTM in a pulmonary specimen. And then there is also the potential with solid medium and smear positivity that you actually can do direct antimicrobial susceptibility testing. In terms of patient management, it is important to know if the culture is negative after 2 months of treatment. As you know, if even in a susceptible case, the culture is still positive, then you actually have to extend the TB treatment from the normal 6 months to 9 months. So that's why it is very important to check about this benchmark for 2 months on treatment being already curative or not. And of course, since we have rapid testing, it doesn't make sense if the testing is batched once a week. So ideally, it would be nice if the healthcare provider has access to molecular TB testing 7 days a week. Now, the toolbox 2 actually comes into play when we have a positive culture, something grew on broth-based media or agar-based media. And so again, if we didn't do a NAT before, the first question to answer is it TB or not? And finally, identification with TB complex, I will talk about that. Then, of course, rapid molecular resistance detection. And more laboratories are moving, like in general bacteriology, to MIC testing, which actually gives you a little bit more information than just drug resistant or susceptible. And then in terms of population management, we are all aware that all TB strains are actually subjected to genotyping, and CDC contracted one state laboratory, the Public Health Laboratory in Michigan, to do the genotyping, and they are moving into also the space of whole genome sequencing together with CDC. So again, focusing on the quality testing requires a quality specimen. So if you have molecular testing, it doesn't matter how good your laboratory is if your sputum, for instance, here 5 to 10 ml, which is ideal, we have just a spit or a saliva or less than 1 ml or so, then the saying is garbage in, garbage out. It's really important to check for the quality of the sputum sample. And I know the presentation will be made available later, so I wrote down a few requirements about sample quality and rejection criteria. Every laboratory needs to have characteristics and define what is an acceptable specimen and what are the rejection criteria. So for instance, we are not processing a sample without the patient's name and all the identifier. We are not processing any specimen which leaked, because you don't know, it's already contaminated. And so these are just a few examples why we reject some samples in the laboratory. The sputum, it is really important to instruct the patient on the proper method of sputum collection, and that we have really a sputum from the lungs and not saliva. And if the patient cannot expectorate a sputum by him or herself, then there is the option for induced sputum. And it is very important to label that sputum with induced, because it is watery, and otherwise we actually would reject the sputum, because watery samples is not a sputum, but that's why it's very important to label it as induced sputum. And you also know 3 consecutive specimen in 8 to 24 hour intervals, at least one being an early morning specimen, because the early morning specimen usually is more, is yielding more AFP, is more productive because overnight it had an opportunity in a way to collect itself. And do not pool any sputum specimen because it increases the contamination. CSF, I don't want to go into here. Gastric lavage, just so you know, there are some details about these 2 sample types. And with the CSF, for instance, we would like to have 5 ml, but oftentimes it's less than 1 ml because first it goes to the chemistry lab, and then it goes to the bacti lab, and then it goes to the mycology lab, and then what is left over we ultimately get, and that's of course not a good strategy. So if the physician has a suspicion for TB meningitis, it is important to get at least 5 ml, or ideally even a 10 ml, which is possible to get from an adult. The same for abscesses and blood. With the blood, especially in immunocompromised patients like HIV positives and so on, when they are symptomatic, TB, but also NTM are frequently seen, especially in those patients which are not under a heart treatment, because the heart treatment actually reconstitute in a way, elevates again the CD4 counts, and so your host immune response is still working. In the early days of AIDS, when we didn't have heart regimens, then the CD4 counts were way below 100, and therefore TB and NTM were not fended off. Direct detection to NAT, and I mentioned that even before AFP, because it can be done faster than AFP. And so the FDA approved the first MTD from GeneProbe, now Hologic, for smear positive December 95. So more than 25 years ago. The smear negatives were followed up with 4 years later, and CDC came out in January 29 with a so-called universal indication when there is a TB suspect, and we are talking here about a pulmonary TB suspect, then at least one NAT test should be done. And then, of course, in a way, the paradigm shift with the 2013 FDA granted market authorization to a cartridge-based assay. This is the term which, for instance, CLIA as well as CLSI, the Clinical and Laboratory Standards Institute, they cannot use company's name, but we all know what that means, cartridge-based. That's the expert. And for the first time, they were able to process the sputum independent of smear and culture microscopy, and you don't need a BSL-3 laboratory environment, which is more expensive to maintain and to operate than when you have just a BSL-2, where you actually can do, or even BSL-1, because you don't need necessarily a laboratory to do the gene expert performance. So this is in a way the quote from the CDC recommendation 2009. NAT testing should be performed on at least one respiratory specimen from each patient with signs and symptoms of pulmonary TB, for whom a diagnosis of TB is being considered but has not yet been established, and for whom the test result would alter case management or TB control activities. So this is a long sentence. It could be written by Shakespeare, but it has all the ingredients why, when you have a TB suspect, a NAT need to be performed. And even the first NAT was approved 25 years ago. We are not where we should be. I think maybe nationwide with all the patients, I think we have 50% of the TB patients who actually have a NAT. So we still need to work on that. So when you have an independent molecular assay, which may actually not be performed in the laboratory, then it can be a point of care. And the nurse, nothing against the nurse, a nurse is doing it if she or he is trained on, no big deal. So then it is important that an additional sample is really sent to the laboratory for smear and microscopy and culture, because ultimately we need to do susceptibility testing beyond the rifampin, which is included in the expert MTB RIF. So that is very important, and since TB control is in a way like a case manager, so one needs to make sure that if an expert or a laboratory developed test is done, that also the either the same sample or another sample is worked up for smear and culture. So what is the difference of the AFP smear positive patient versus AFP smear negative patient in terms of NAT? The MTD was the first to come out. You see with the AFP smear almost 97% sensitivity, but on the smear negative, only 3/4, 76. So that means there are 24% for the MTD, for instance, 24% of patients who are smear negative but culture positive for TB, and that's why it is so important to have cultures done as well. And then the laboratory developed test, it's more or less the same, and the expert, the first study, they are always better, the trials data compared to the day-to-day in the field results. And so you could say, rule of thumb, NAT testing in AFP smear positive, almost 100% sensitive, and in smear negative culture positive, it's only 3/4. So with our words, if a NAT test is negative, then of course TB is not ruled out. And if you have an AFP smear positive patient and the NAT test is negative, hopefully the quality of the specimen was okay, because when you have a negative result, a less quality sample is of course also producing a negative result, meaning a false negative result. So here again, it is very important to make sure that the quality is what it should be. And so, as I said, with AFP smear positive and NAT negative, then of course your thought goes towards non-tuberculous mycobacteria, and when smear negative and the NAT test is negative, then you cannot rule out TB. So how powerful is actually the NAT test? And this is a study from Orange County in Orange County, California, not Florida, 1 NAT versus 3 AFP smear and culture results combined. And so you see the smear result, and this is the smear result, stops about 70% here. Usually it's maybe 55, 60% of all the culture positive TB cases. So it's a little bit higher, 70%. But you also see 90% for the NAT being positive. So a single NAT, already 90%, and you have the result in a few days because sample collection, sending it to the public health lab via mail or courier takes some time. And then the liquid medium here, this was the Bactec 460, the radiometric version is not any longer in use. Now we talk from the same company, Midget. So, but here again, as you know, not all TB cases actually are 100% culture positive. So here we have maybe 95, but by week 6 or 5, I should say. And then the solid medium, the Löwenstein-Jensen, almost the recipe is 100 years old, and then Middlebrook plates, we had them from the 60s on, so they are capping off maybe by 70%, but the combination is what is important. So here again, see the important impact in terms of early diagnosis of a single NAT versus the smear and the culture. So this is again the reason why we really need to have more NAT testing done, respectively ordered by the clinician. Decision to discontinue upon infection isolation in healthcare setting. So far we have talked about ruling in tuberculosis while we are using a NAT test. And now here we are talking about ruling out TB in a TB suspect. And the decision to discontinue is again very important, that your quality, your sample is of the highest quality. If this is false negative, then of course you would start a disaster if you have a TB case, not negative because the sputum was not a good sputum. And if you would just plainly rely on a laboratory result and release that TB suspect, actually a TB patient, from airborne isolation, would be a real catastrophe. So it is important that we monitor the quality of the specimen. And of course, TB suspect should not be released only on a single laboratory results. There are signs and symptoms, there are x-rays. And so for instance, in California, if somebody is in respiratory isolation and it was a TB suspect, then TB control actually has to sign off because they are the real expert. And just to make sure that not a TB patient is by mistake released from airborne isolation. I mentioned that already, and the National TB Controller Association, together with APHL, the Association of Public Health Laboratories, when the FDA actually approved this additional label, saying 1 or 2 NAT is okay to release TB control, and the laboratory people got really nervous because of the quality issue of a single sample. And that's why this consensus statement, which is available on both professional societies, are on the website available. Now, the San Francisco people actually did a study. What is the impact of this new FDA label with a good quality sample of a sputum, and do the expert, and they did this now already 6-7 years back, and it was amazing that actually per patient they were able to save $13,000, and so they calculated the estimated utilization and cost for approximately 250 completing TB evaluation each year, and projected total annual savings of more than $3 million to the hospital. And believe me, the CEO and the chief financial officer in the healthcare setting, they love that. So we can help the patient not staying unnecessarily in a respiratory isolation, and we are helping in a way the institution to save money when we actually use more NAT. Acid-fast bacilli smear microscopy. This is the Nielsen staining carpal fuchsin, and so you can see these red rods, or some say these are the red snappers. And what is recommended is auramine, rhodamine, or only auramine fluorescence stain. And so here you see them again a little bit curved, a little bit elongated. So this is a typical TB. An avium would be much shorter. The Xenopi, for instance, NTM would be much longer. The Kansasii is beaded. So you have, when you have experience as a microscopist, you can identify to have a little bit a hit, but you never identify the NTM or TB based on the smear microscopy. We just say AFP positive and say what how many we actually see. And so here there is in a way the CDC recommended a table. So you have AFP number per view field, and the 1000x magnification requires early immersion and is usually with carpal fuchsin Nielsen. And then when you have the fluorescence, you can have a broader view field. So since you are using only 250x, and so you screen less fields, and so you have here the exact number how we come up with our no AFP seen. We don't say negative because we cannot say that. It takes about 10,000 AFP in a sputum per ml to show up actually as smear positive. So that's why we say no AFP seen, then doubtful, and please repeat, then 1+, 2+, 3+, and 4+. So here one question I think the audience had was, what does that mean, doubtful, when you see only 1 or 2 in your 300 fields, respectively 30 fields? And so here from CDC, doubtful, repeat, and ask for a second specimen. So this is a CDC. Now, in the laboratory, especially College of American Pathologists, CAP, accredited laboratories, most hospital labs are this. The CLSI guidelines published here 2018, they say also no AFP seen, report exact count, recommend submission of a repeat specimen, and then here they say only 1 to 2 AFP per 300 field is not considered positive, but indicates that another specimen should be requested and another smear made from the new specimen. So here, that tells us it's not always easy to know exactly what you see actually is a AFB bacterium, or if it's an artifact or whatever. But here again, if you have a 1+, of course, my response would be, I would do another NAT if a NAT is not yet already done, because the NAT, as you know, in smear positive is 100%, in smear negative, even if that is quote, quote, false negative with these 1 or 2 bacteria, then when you have a NAT and it's negative, then it's a different ball game. Or if you come up with a positive NAT, then of course these 1 or 2 AFB really mattered. So it's really important to know the smear microscopy is not an exact science. And if a second person would read the same smear, the person may view different view fields and may come up with no AFB seen, or maybe with 3 or 4 seen. And so that's why it is really important not to discount this result, rather to ask for a second sample and to recommend that the NAT being done. Growth detection, here on the left side, this is not AFB, this is a gram stain of Staphylococcus aureus. And on the right side, you see here again the Thiel-Nielsen, but since there are so many cells here, it's really not easy when you have only 1 or 2 AFB to actually recognize them. So, but the important thing is, of course, we all demand instant results. However, in terms of culture, the Staph aureus or strep or salmonella or E. coli, they have a generation time of 20 minutes. TB, on the other side, of 20 hours. So with other words, we will never see the next day with your eyes a positive colony. So we have to incubate 6 to 8 weeks, and usually TB cultures may be positive 2 weeks, 3, 4 weeks. And while when you have a sputum for bacteriology the next day, more or less you have everything what you may see. Maybe you incubate a day later, but not weeks later. So here again, because of the long generation times for mycobacteria, and as I said, TB 20 hours, and leprosy, the Mycobacterium leprae bacterium, we can't even cultivate in artificial medium. And so the NAT again is the answer. In terms of sputum processing, in order to kill the other flora, as we call, whatever is fungus, candida, or strep, staph, pseudomonas, other gram-negative organism, we need to kill them. But we also need to appreciate that with this decontamination process, we kill also the majority of the AFB organism in order to get a pure culture. And so with other words, if a laboratory says, we don't have any contaminated sputum culture result, that's actually a bad sign. They may decontaminate, over-treat the sputum, and therefore they have no contamination rate, but they most likely have also a lower yield of AFB bacteria, because they not only just kill 80 to 90%, they may kill 100%. And so about 2 to 5% on Löwenstein-Jensen, this is just a historical marker. The solid medium should be culture positive. When it goes to towards 0, this is not a good sign. When it goes to 10% or higher, it's also not good a sign, because you may lose the solid medium due to contamination, and your AFB is never growing in this mess with fungus and the contaminating organism. And that's why I bring again back the powerful impact of one NAT versus 3 smear and culture in terms of sensitivity, specific for, and especially rapid turnaround time. Identification, and in these days the NTM are part of it. I looked up our list where we keep track of all validly published species and subspecies. The genus Mycobacterium contains, as of yesterday evening, 194 different species and 13 subspecies. And there is the MTB complex. You have M. tuberculosis, you have M. bovis, Bovis BCG, Africanum, and then a few others in animals which we rarely seen, but they are very closely related to tuberculosis and belong to the TB complex. So just to give an idea, this is data from 2000 at the Wadsworth Center. And here you see about 95% of all the cases they diagnosed at the Wadsworth Center, New York State Health Department in Albany. There were TB, 2% Africanum, 2% Bovis, and then one of these rare ones, Capre and Bovis BCG. And you may wonder, why do we see Bovis BCG? Why do we see Bovis? I give you the answer here. So in 2001 through 2004, New York City had 35 cases of human TB by Mycobacterium bovis. And then, of course, they recognize this is way above what you would anticipate, especially since we know bovis is transmitted usually via unpasteurized milk. And as you know, in New York City, there are no cows. So what's going on here? And then the EPI people did their work, and USDA did their work, and they were able to identify that these people, especially from Mexico here, they ate unpasteurized cheese from a particular area in Mexico. And of course, for them, for the Mexican people, this is gourmet, and you are allowed to bring them in, even if you bring them in suitcases, as long it's only for yourself and not for sale. So the Mexican in New York City, they prefer their special cheese, and it's unpasteurized. However, of course, the cows producing the milk, obviously they had TB, and this is how they get it. So with our words, the Mexicans do with their cheese like what the Swiss do with their chocolate. The American chocolate is not as good as the Swiss chocolate, and so maybe the American cheese for these Mexican people is not as good as what they are used in their homeland. And then here, the Bovis BCG and all these cases I mentioned from Wadsworth Center, almost 2%, they were all cases, bladder cancer cases who were treated with M. bovis BCG. And of course, when you instill the attenuated bovis BCG, and it's not the same formula like for the vaccination of with BCG into the bladder, you know, when you insert a catheter, sometimes it bleeds a little bit. And so that means if something is coming out, then when it's not intact, the linings, then the BCG can escape and settle wherever. It can be a knee abscess, it can be a scrotal abscess, it can be whatever you imagine. And so this guy came in, they had suspicion for a lymphoma or a dissecting aorta aneurysm. And so you see the trachea is not going straight down, and you see in a different imaging the extra mass here. So they did a fine needle biopsy, and originally was actually diagnosed as M. tuberculosis, and then it was monoresistant to a PZA, and then we did the further testing, and it was a clear BCG. And so with other words, we shouldn't forget that BCG we may also have, and when it's only AFB positive or TB complex for TB control, this is a TB case, until the same with the bovis for TB control. Activity is really important to identify the bovis. It's really important to identify TB complex because it could be a BCG case behind. For integrated healthcare delivery systems, 91 through 07, the most frequently organism with NTM pulmonary disease was avium complex, avium intracellular, chimera, and so on. And then next, but with 12%, the abscesses and cheloni, they are thrown together because not every laboratory in these four settings actually identify the abscesses or differentiate the abscesses from cheloni. Then fortuitum, Kansasi, Ischemia, and Xenopi. So these are, I would say, the top 6 in the United States and even in Canada. Xenopi is a little bit more prevalent in northern state and also in Canada. Antimicrobial susceptibility testing. The reference method is Agar proportion. It's a solid medium. We can report out percent resistant colonies. We recognize if it's a mixed culture because we see colonies. Incubation is 3 weeks. Broth-based method, that's the reference for WHO, more or less Midget or Versa has a Versatrek has a shorter turnaround time, is a walkaway system. And as I said, more and more laboratories are shifting to MIC testing. And so here from the CLSI, 2018, the different concentration, the fluorescence based, as I mentioned, they cannot use commercial names, would be the Midget, and the pressure based would be the Versatrek. But you also see that the concentration is not always the same. So you have ethambutol 7.5, here 8, and here 10. Or even the higher concentration for INH 0.4, 0.4, and 1, or with streptomycin, you have here 1 and 4, and here 2 and 10, with the agar Middlebrook 7, 10. So it's really important to know which media is used and what concentration was tested. And the WHO technical report just came out in January, analyzing thousands of results, ultimately decided to recommend a lower concentration for rifampin in 7H10 from 1 to 0.5, and here also Midget from 1 to 0.5. here there was not enough data, and we didn't address this at all, the Löwenstein Jensen, because the issue with rifampin was really in the midget, because we have TB strains with elevated MICs, and when you have one, then they may be reported out as still susceptible versus resistant. And when you look on the molecular side, they have a point mutation, so it clearly should be resistant, and the clinical outcome of these patients are not as with rifampin susceptible. And the sensitivity and specificity of the various genes, RPOB, CACHI, INHA, EMBB, PNCA, gyrase A, this, if you are not familiar with that, drug-resistant TB, a survival guide for clinicians, this is a wonderful didactic source. It's available, of course, in Curry Center, and you can download it, the third edition from 2016. It's really very educative. So I recommend you are looking into this in your leisure time. But there are limitations to molecular testing, potential to identify mutations that do not confer phenotypic resistance. Not every mutation means drug resistant, and then not all genetic loci associated with resistance are known. Therefore, no mutation detected does not rule out resistance. So this is very important to keep in mind here again. It's not absolute, it's not black and white, but with experience and proper documentation from the laboratory, you should be able to evaluate what is going on. And really hot off the press, it was published just a couple of weeks ago, a WHO catalog of mutations in MTB complex with their association with drug resistance. And they covered 15 antimicrobials. They put together results, and this is all sequencing results, and high quality sequencing results, because sometimes on the internet what is posted is really garbage because it's not curated. And these 38,000 isolates, of course it's biased towards drug resistant, they found more than 17,000 different mutations. And so if a laboratory identifies a mutation, now they can look up what does that mean? Is that really conferring resistance or not? Or we may not have enough data, and then of course we cannot make a call about resistance or not. Molecular drug detection of drug resistance, of course, the indication here, some people say, I do this only when the smear, AFP smear is positive. Some do it only when drug resistance is suspected, and we know how well we are there. A susceptible population has been exposed, or the culture is mixed or non-viable, so regular antimicrobial susceptibility can't be done. And as you all know, CDC offers a wonderful service, molecular detection of drug resistance program, which has the normal drugs, but also ethambutol and PCA. And for me, whenever there is a TB case, we need to have molecular drug resistance, because again, it goes faster, the turnaround time, and the reference method is not necessarily the gold standard, because remember, when we have only 10 or 20% of the entire population, who knows that we actually have the majority of the AFP load in our culture, or if the significant ones be killed off. And that's why with the molecular, where in a way it doesn't matter what the percentage is between drug susceptible and drug resistant AFP. So you have an opportunity to have a faster result and also a sort of a confirmation. Systems algorithm, I see we are getting close here. AFP service performed. You have almost 600 laboratories who participated on this survey. They do AFP smear microscopy and then culture, already less, and then significantly less laboratories who do the identification within the MTB complex or first line and second line susceptibility testing. And that time, you see, direct testing in 2011, even it was then already 6 years FDA approved, was really not very often done. And then the algorithm, I don't want to go into this, but here again, I'm more than happy if you send me a request for this practice guidelines for clinical microlaboratories, Mycobacteria 2018. I'm more than happy to share this PDF document where you can learn more about what's going on in a TB laboratory. This is a slide which I received from New York State. They have the whole genome sequencing implemented, and they started in 2013, and now so far by 2021 they have done more than 3,000 TB genomes, meaning they did whole genome sequencing in terms of what does mean whole genome sequencing. The entire genome of the TB was a sequence, so they can say which lineage in terms of genotyping it belongs, the drug resistant pattern, the identification if it's Bovis, BCG, or whatever of these rare TB complex species from animals. So they are really, in terms of public health, I think the leader in the country. But when you do something which is not available in a kit, like a pregnancy test, then it takes a while with all the validation for laboratory developed tests. And here the algorithm, I leave that with you as well. The processed specimen, respectively isolates they receive, they have a molecular testing arm and then a culture arm, and they do this in parallel, because some results on the molecular you have way earlier than on the culture side. And as you have seen, the whole genome sequencing for them, as they have it now fine-tuned, the report goes out in less than a week. So this is really tremendous progress. Now, result reporting, this depends on laboratory information management system. The functions of such a LIMS is electronic laboratory testing ordering, and then of course the resulting. Billing is always, the finance department is always very interested in it, because they want to make sure whatever we do in the laboratory is billed for. When you are in a hospital or in a reference laboratory, then you can define the algorithm. So if somebody is ordering AFP smear and culture on a patient with a sputum collected, then you can actually define an algorithm that he can order this only if at the same time a NAT test is ordered. This is what we mean with algorithm. Then inventory management, sample-centric versus patient-centric. Of course, laboratories like to see this from a sample perspective, but TB control, infection control, they like to see that from a patient perspective. So there are different ways. Integrate instruments, so you don't record what an instrument resulted then manually into the LIS or LINS. Audit trails, whoever did change something, we have tracks, then data storage and sample management. And of course, like with cars, you have plenty of different vendors for LIS. And I asked a few, a friend of mine in the hospital and in the public health arena to share with me some de-identified results. So this is from Tyler, Texas. They did the identification microepithelium by sequencing. And then what is important, these guidelines, when there is 100% identity, when there is 99 versus to 99.9% identity, and when it's lower, then of course there are different criteria how to call in a way the identification as 100% match or looks like M. avium or so. Then the references, and then of course the laboratory director. Then this is another one. Some actually have their limbs not purchased from a company. They have their own team, like here at the Wadsworth Center. I think there is a 3 or 4 member team, full-time employees. They are working on improving and making changes to the LIS all the time. And they developed it themselves. And in COVID-19, whenever a new organism comes out, they have a little bit an advantage because they don't have to go through a company for major changes. So here, direct molecular drug susceptibility detection, pyrosequencing, they say the method, then rifampin, INH, and the CACHI and INHA too. But you also see the sample was 1026 reported out as AFP positive, then real-time PCR 1 day later, the avium complex not detected, so it's not mixed. Then they were able to say MTB 1 day later, and 2 days later then the molecular. So in a few days you have really already a good sense what's going on with this patient. This is a hospital lab. They have sputum expectorated. It's a positive in terms of MTB NAT, the rifampin resistance not detected. Then they explain what it actually is, what they did, and what the performance characteristics is. And specimen collected. This is always important to have the date. And this is another one from the same hospital. And they even, let me see, this is North Carolina State. So they had a TB case, but they don't do susceptibility testing in-house since it's a low prevalence state. So they actually sent this out to the state laboratory. And so here they have then the PDF document of the state laboratory in the hospital LIS. Off-label use, the expert, they also, not only the time and the date of the collection, it was a sacrum abscess, and it was a TB positive. So they have also the name of the person who collected the sample. So all this information is very important. Then here, National Jewish, the interesting part, they already You see here the rifampin 0.5. So they changed very quickly according to the WHO guidelines. The CLSI did not change it yet, but they are in the process to change. So they already made that change. So that's important. And here the method, the midget. And here from another hospital, they actually had the culture positive. First, they have reported this as M. tuberculosis complex. And then they actually say here, corrected. This is a corrected results, previous organism was blah, blah, blah. I will call this actually amended because the first result is also corrected, just not as specific. So what I'm saying here, whenever you change something in the LIS, you actually cannot override what you are changing. So you still have a history, what's going on in the reporting. Then the AFB notification, they notified the so phone faxed which time and date to whom, and then one also asked them to read it back so one understands if they actually understood what you communicated. And it's not only phone, so you also fax. This is from Public Health Agency Canada. And now we come to acknowledgement. These are all the laboratories who provided me with some reports. Beaumont Hospital, the State Lab in California, National Jewish, Canada, Stanford Healthcare, University of Texas, Chapel Hill, Wadsworth Center, and I mentioned Kim Musser, who gave me these 2 slides I mentioned about the whole genome sequencing, which is done in this public health laboratory. And with that, I say thank you for the opportunity to be with you today. And these 2 pictures, actually, I took myself. I'm a nature photographer. So maroon bells in Colorado, or some of the birds here, the rose-eared spoonbills in Florida. So this is what I do when I'm not concerned about AFB. If there are any questions, and if we have time, I see I went over, but if you have questions even after this presentation, feel free to send me an email, max@usf.edu, and just refer to our event today, and I'm more than willing to answer any questions if we don't have now time to answer any urgent question. So with that, Olivia, I give it back to you.
Thanks so much, Dr. Salinger. And it looks like, we are a little over time, but if you have a few moments, maybe we can see if there's any questions from the audience. I have
time.
Okay, wonderful. Yeah, I don't see anything in the chat box, but if anyone has questions, please feel free to type them in there, or you're welcome to unmute yourself at this time as well to ask questions.
Hi, Dr. Salinger, thank you for doing this for us. I do have one question. And it's regard to, like, when we see a lab result that says PCR. So from my understanding, and you can tell me if I got this right or not, a PCR would always be reported as a NAT because TB has to be amplified. So if you've seen a PCR as far as TB results, it would be considered a NAT?
The NAT, the term is the generic term. PCR was the first type of amplification. There are several ways how you can amplify. And as I said, PCR was the first. It's almost like Kleenex and napkins. Even you are purchasing maybe not Kleenex, but you still call it Kleenex because Kleenex was the first type of these napkins. So I see this similar. We call it a PCR because it was the first one, but the generic name would be a nucleic acid amplification test NAT.
Okay, that makes more sense to me. Thank you. And, you know, I know you were talking about the sputum and it should be 5 mLs, but would you more likely, I mean, if we get it, we send it and they'll let us know that it wasn't enough, but they'll still run it, or at least our lab does. And, but you would not necessarily get a false, you know, if it's positive, it's positive. If the specimen, you know, even if it's
yes,
inadequate.
that is true. And this is why the laboratory, even if they quote, quote, reject a specimen, they actually don't throw it away, because there might be other circumstances why there was not a better quality samples being collected. So we always call back and say, hey, this is not good. It would be good to have another sample. And when then the healthcare provider says, this is all what we get, then we say, we will do it, but we will have a disclaimer on the result. As you said, if it's positive, it's positive. If it's negative, then it might be false negative. And that's why we may add a disclaimer saying this is not enough volume or whatever.
Okay, thank you. And Olivia, I don't see any questions in the chat. I don't know if you have any last thoughts.
No, I don't see any other questions as well. So maybe we can go ahead and wrap up. Like Dr. Salinger said, he did share his contact information in the slides, which we'll make available. And he says that you're welcome to reach out to him as well. So thanks so much, Dr. Salinger. And everyone, thanks so much for participating again this week. The recording and handout will be available on our website. And of course, you can always find more information on our TB 101 webpage. And we'll see you all next week for our treatment of TB disease presentation on August 5th. So Dr. Salinger, thank you so much again for joining us. And everybody have a great rest of your week.
Thank you again for having me. I enjoyed very much the presentation and to be with you. So all the best in the fight and TB.
Thanks so much, Dr. Salinger. We appreciate you taking the time to join us.
Thank you. Bye-bye.
Bye. Thank you.